Great. Well, welcome. We are trying to put together this lecture series to cover some of the things that we think might be important for the critical care of these patients as they presumably become more in number. What I think is interesting about these people is that despite the fact that they have a virus, a lot of them get septic shock. So that's kind of weird. And we'll kind of go over that piece of it as well. When I thought about how best to give this, I have these slides and I give this talk like a couple times a year to different resident groups, but really it seems like what we're going to encounter is hypotension, and you're going to wonder, why are they hypotensive? And one of the reasons they could be hypotensive is septic shock. And that, if true, is going to spur a bunch of very specific things, which is why we're talking about it. But obviously not all hypotension in COVID-19 is septic shock. So we may spend just a minute or two covering what that whole list of things would be. And I think a lot of easy things come to mind. Obviously, the sedative effect and the effect of positive pressure ventilation, which we routinely see in the ICU, will be common with these people as well. Because ARDS patients are often diarrheal, or the idea is keeping their total body volume low, those effects of sedation, positive pressure ventilation will be enhanced. Other interesting causes of hypotension are going to be adrenal insufficiency. A lot of these people will be intubated with etomidate. Yes, in 2020, that's still true. And as a consequence of that, they're at risk for adrenal insufficiency, which can cause hypotension. And then the myocardial dysfunction that people have maybe heard about coming out of Washington is another important cause to recognize, because again, the treatment will be different. Setting that aside, it would be worth talking about kind of how to distinguish between those different things, but and we can maybe do a little bit of that at the end. I'm getting a text from Alan saying he can't get in. I'm assuming you're all getting that and hopefully trying to help him. So when you then settle on, okay, well, I don't think it's the sedative effect because we're not sedating him. I don't think it's the ventilator positive pressure effect because that's kind of minimal. He's got a fever and he's got a white count. So I think this is septic shock. So you've now made this diagnosis, and that's kind of where we're going to pick up today. And so we'll cover a little bit of the pathophysiology and the management. How to define sepsis helps you diagnose it, so we'll cover that. We'll talk a little bit about the epidemiology, who gets it, what kind of bugs we usually see, and then kind of de-emphasizing a little bit the underlying physiology. I don't think we need to know about, interferons and toll-like receptors and that crap, but just sort of the basics on that to understand why the patient looks the way that they do. Some of the consequences of organ failure, and then lastly, most importantly, how to then manage those patients. And the good news is that there are a lot of protocols and guidelines and rules around how we treat this. So to some degree, it is algorithmicized, but I think still worth talking about and going through. We want to try to get through it without saying early goal-directed therapy. This is a thing that, it's sort of funny, like when 20 years ago, when people first started talking about this, everybody said, oh, early goal-directed therapy, this and that. Oh, I can hear someone's voice, which is fine, but, and the wind. And then people said, oh, no, early goal-directed therapy is terrible. You got to do this other thing. And then this other thing is exactly like early goal-directed therapy. So so just stare at this slide in wonderment and remember that when we get to the management part. So it used to be that we define this as SIRS, which is a systemic inflammatory response syndrome, plus signs of infection. And people in the group, I imagine, are familiar with this concept of SIRS, but basically it's you look sick, you might have a fever, you might have a white count, you might be tachycardic, you might be hypotensive. And if you have enough of those things, you are SIRS positive. Well, now we don't use SIRS, we use SOFA. But it's exactly the same. If somebody's outside in the wind, I might ask you to mute yourself. And if I have to, I'll go to the participants window and see who the guilty party is. Oh, good, they fixed it. So we don't say SIRS anymore, we say SOFA. It's basically exactly the same thing, with the caveat that it's particularly focused on organ failure rather than vital signs or lab signs. And we don't say SIRS, sepsis, severe sepsis, septic shock. We now just say septic shock. There's an emphasis on the host response, which is this inflammatory response that people talk about and can see cytokines and hypotension and things of that nature. And we'll talk about a little bit of that. So with this rushing in of SOFA, or the sequential organ failure assessment, the way you would want to think about this from your perspective is, if this patient has a lot of stuff on the SOFA positive, then I think it's more likely that they have septic shock and that they are at a higher risk for mortality while they're in the hospital. And there are functional definitions of the SOFA, and you can see this slide, I hope, that along the y-axis is all the different organ systems, basically, and along the x-axis is ascending scores of severity. So the worse off you are in each one of those organ systems, the higher your score, and the higher your likelihood of mortality during your hospital stay. And these are not surprising things. You know, if you're on a bunch of pressor, your score is higher. If you're, you know, bleeding and not making platelets, your score is higher. If your P to F ratio is terrible, then your score is higher. So it's intuitive that the higher scores here would do worse. See, in theory, you would add up all these numbers and say, oh, this person's an 8, they're going to die. They probably have septic shock. Not helpful in and of itself, but used as a screening tool, there is a kind of shortened version of this SOFA, and this is what people use out on the floor here and at Parnassus through the EMR to identify like who is likely to have sepsis and therefore needs to be seen by a human. And that abbreviated screening is really just the respiratory rate portion of the SOFA and the blood pressure portion and the altered mental status. So that's called a quick SOFA or a Q-SOFA. So you could kind of use that as a very crude screening tool to say, hey, like this guy's sick, we want to think more about whether he could have sepsis. Again, because treating sepsis quickly can dramatically improve the outcomes. So I would kind of leave the SOFA at that and just think of it as kind of, how do I screen people for sickness with sepsis. This is a picture of the thing that we just talked about. I stole this from the Parnassus slide deck. And then I don't want to get into the whole thing comparing SOFA and SIRS, but in the same way that we compare early goal-directed therapy with not early goal-directed therapy, it turns out they're exactly the same. The SOFA and the SIRS are basically exactly the same. And these differences that you see here in terms of their ability to predict who's going to die are statistically significant, but clinically totally meaningless. And yet people geek out over this till their heart's content and say that, you know, SIRS is terrible, SOFA is great. They're both terrible, but they help you think about like who might be sick and who you want to deliberately focus your attention on. So that being said, we're going to move on to actual septic shock stuff that's a little more interesting. So this is common. So there's no there's no ribbon or like 10K for sepsis. I suppose the ribbon would be green if it were, but this kills a lot of people. Almost 1 million cases a year, a high mortality between 25 and 35%, depending upon the study you're looking at. And just out of comparison, you know, breast cancer, coronary disease, other things that we think are bad and that have marches, by the way, not quite as fatal as sepsis. The incidence is increasing. This is an old slide. I don't know if it's still increasing. We are much better at identifying these people, in part because we have an electronic medical record that will screen for them automatically. So maybe sepsis is more common, or maybe we're just better at finding it. And then these people use a lot of ICU beds, and they, compared to other things that end up in the ICU, they stay longer and use more resources. The sources of infection in sepsis are things that you'd imagine: chest, abdomen, and urinary sources, again, so like pneumonias, tracheobronchitis, abdominal abscesses, and then things like UTIs and pyelonephritis are the common causes. But there are a lot of other causes that we miss a lot. And I think I maybe took these slides out, but if you look at autopsy samples of patients who have died from septic shock, the vast majority of them will have untreated or undertreated infections. And across all comers, about 10% of those people will have gynecologic sources of infection. And we obviously don't think about that a lot at the VA because we don't tend to have female patients, but it's important to remember that these exist and that they, in mixed populations, are a relatively common source of infections leading to septic shock. So even though the ones you see here, chest, abdomen, and the UTI are the most common, they're certainly not the only ones. Generally, this happens to older people, and typically, you have some other thing. Not that it never happens that just a regular person doesn't get pneumonia, get septic shock, but generally speaking, um, there's some other set of comorbidities. In the same way that people that get coronavirus who get sick tend to have other stuff. If you get pneumonia and get septic shock, you tend to have other stuff going on as well. As I said, the mortality is kind of mixed and depends on the sample you're looking at, and we'll actually talk a little bit about that. Compared to STEMI, for example, 8% of people die within 30 days of that. It's more like 30% with septic shock. What is actually happening inside the patient's body? And again, I mentioned this before we started, and I'll mention it again. Please unmute yourself and interrupt if there is a question. By all means, I will not see if you post a question on chat, but definitely feel free to unmute yourself and pipe up and interrupt me. That would be great. There's different levels to kind of look at sepsis from the gross level to the actual infection, the host response, and the inflammation. All of these things have different like pathophysiologies. And it's worth talking about each one kind of a little bit. The gross one, just because you get to see like kind of cool pictures, and I'm going to fast forward to that. So the gross is that there's an infection, right? So you have these gram-negative rods here, gram-positive cocci. There's a virus. We interestingly I don't think I've ever actually seen viral septic shock in 10 plus years of doing ICU medicine until now, this coronavirus, but apparently it's a thing. There's a parasite. You can get infections from parasite. By the way, I don't think this parasite would probably cause sepsis. It's too big, but when you Google parasite, like this is what you get. It's pretty gross. And then fungi can cause sepsis. We see that at Parnassus a lot in the immunosuppressed population from the Central Valley. They all come in with cocci. If you had to guess, you might think gram-negative rods account for the most sepsis, but I think maybe those patients are just a little bit more severely ill. This is a relatively recent breakdown of the kind of total organism load, or what types of organisms people have. So gram-positive cocci take up the lion's share of that, and then most of those are going to be staph and strep. On the gram-negative rod side, you've got your E. coli, Klebsiellas, and Pseudomonas. And knowing that distribution for your center be important in making decisions about antibiotics, which we will touch on. This is German. This is fun. This slide's like 15 years old now, and this kind of stuff actually happens. So how do you diagnose what the organism is? Well, you give a bunch of antibiotics, you send a bunch of cultures, and you hope that something grows out 3 days later, and then you tailor your antibiotics. But there are places in the world where they just send a blood test and say, oh, you've got DNA from E. coli, so we're going to treat E. coli. Test comes back in 6 hours, you're good to go. And this seemed like a fantasy, 10, 15 years ago. But I guess it still kind of is because we don't use it. But more and more things like this probe are being used. We have the BioFire here for stool antigens or for stool pathogens, and we have all these respiratory viral panels for things that are, again, not growing things in culture, but looking for their DNA or their genetic footprint to say that they have it. And those things are obviously much faster. So this clearly the way of the future. We'll get there someday. So I used to think when I was a kid that when you get septic shock, the bug just eats you up and like it destroys your tissue, but that's not at all what happens. The bug just sits there and interacts with your immune system. It's actually your immune system that wreaks most of the havoc. And these are all of the things that stick off of the outside of different bugs that interact with your immune system. It's not super important to get like deep into the weeds on that, but what happens is that you have these cells of your immune system that receive messages from these extracellular components, and then create this host response, which is your immune system kind of going crazy. So your innate immune cells do a thing, they signal to your T cells do this other thing, they make a bunch of chemicals that I can't pronounce, and then you have this thing, which is just a picture of the whole thing that we usually spend a lot of time talking about. So you have the bugs at the top, and they're interacting with your cells in the middle, and then those cells spit out a bunch of chemicals that make the rest of your immune system go haywire and do stuff. And depending upon the scenario, it'll either make you immunosuppressed or it'll make you hyperimmune and super inflamed and ramped up. And we don't know why some people get one and the other. It probably has to do with your age and demographics and how sick you are. But some people get immunosuppressed and some people get sort of hyperimmune. And then all those things contribute to this picture, which I did not make, but which describes why patients with septic shock get hypotensive. By and large, it has to do with vasodilatation, and it's from this whole inflammatory milieu telling your endothelial cells to make more nitric oxide, and the nitric oxide will locally vasodilate those blood vessels, and you'll get hypotensive as a consequence. And so that's what you see when you are caring for these people. They get hypotensive, their organs start to fail because they're not perfused enough, and that all goes back to the infection, how it interacts with your immune system. Hypoperfusion is complicated because you would think that if organ failure was strictly from hypoperfusion, that if someone died, you'd cut up their kidney and look at it and the tissue would be necrosed. But what happens is that's not what you find. What you find is that under the microscope, the tissues from failing organs in these patients look pretty normal. So I think mechanistically, it makes sense to just say, well, you're hypotensive, so your perfusion's down, your organ failed. Like that all makes sense, but I think it's probably a simplified approach. So again, you're infected, there's a host response, there's dysfunction and vasodilation, shock, and hypoperfusion. And that's kind of like what we're trying to prevent when we talk about resuscitating all these people. Yes, there's this immunosuppressive sort of piece over here, which we can't really do much about. We're really focusing on the hypoperfusion because that's where the organ failure comes from, and that's why people die. So these that they're just here. You know, what can I say? There's a picture of cows. So now, so you've made the diagnosis. You understand, geez, this guy's interleukin-6 is like through the roof. What do we do about it? And so that's where we'll get into the management. And really, I think, oh, you got a question? Oh, fair enough. The management is best described by something called the Surviving Sepsis Campaign Guidelines. And this is a group of people that get together every 5 years and talk about the data and give suggestions and recommendations for how one might treat septic shock. And over the years, people have raised controversies about, you know, industry influence and the like. But the reality is it's a pretty well thought out set of recommendations, and you can see the evidence for each of the things that they're suggesting. And I think mostly we do the things that they say. So we will talk about, well, and I should say that they cover septic shock, but also like a lot of the other stuff, like who should get DVT prophylaxis and what should your glycemic range be. So they cover like a lot of kind of general critical care stuff in addition to the sepsis specific stuff. So if you were to kind of memorize the executive summary of that document, you'd probably be pretty good at doing this. Here's where I usually ask the audience, but I can't because you're on mute. You know what the first important thing about the management of septic shock is? And you say, well, source control, of course. And then I say, well, what's the second thing? They say, well, geez, I don't know. And I say, well, it's source control. And I'll say, well, what's the third thing? I sound like Art Wallace now. And they say they don't know. And I say, well, the third thing is source control too. And this just to emphasize that if you are not controlling their infection, all of the other stuff that you do is not going to make a lick of difference in terms of their outcome. And the reason that this is important is because, as I mentioned earlier, if you look, and this has been done about a half a dozen different ways, if you look at autopsy studies of people that die from septic shock, they consistently have infections that we're not treating. So these are abscesses that aren't being drained. These are resistant organisms that don't have the right antibiotics on board. These are areas of infection that we had not considered, like meningitis or tubo-ovarian abscess. And what that communicates is that if you don't have the source controlled, you will not be able to get them over their sepsis. We have to also consider resuscitation and then again, the ongoing management of their organ dysfunction. If you look at the Surviving Sepsis Campaign guidelines, they will say, get cultures, give antibiotics, give fluids, pressors and steroids, and we're gonna kind of take each one of those in turn. And I'm gonna just skip past this part quick. So their terminology is that you should engage in an active, urgent search for correctable causes, which means you are getting cultures. Cultures are part of the picture. We would typically get blood cultures in sets that cover anaerobes and aerobes. We would get urine cultures, and we would get chest x-rays and either sputum cultures or tracheal cultures if they are intubated. There are centers in other parts of the world that routinely CT scan patients as soon as they have a diagnosis of septic shock. so as to identify some of these other alternate causes. There are places that more consistently do lumbar punctures, looking for meningitis, again, to identify some of these other causes. None of the hospitals in our system do that consistently. We generally are in the culture world and then starting antibiotics. And the belief is that you need to start antibiotics within the first hour, and this should be obtained before initiating, then that is, a culture should be obtained before initiating antibiotic coverage, but should not delay the administration of antimicrobial therapy. So when you're debating like, well, I'm ordering the culture, should I get the antibiotics on board? The answer is always to get the antibiotics on board. You might ask, well, what should the antibiotics be? I think this patient has pneumonia, so I'm going to cover pneumonia. Wrong choice. The guidelines are very clear and the mortality data are very clear that the correct approach is broad coverage for all possible organisms and then daily consideration for tailoring based on culture data. What that means here is going to be zosyn or piperacillin tazobactam and vancomycin. If the patient has renal insufficiency, you would probably consider changing the zosyn to cefepime. And if the patient has risk factors for extended spectrum beta-lactam organisms, then you would use a carbapenem like meropenem or ertapenem. You can get into the weeds of, well, this covers that, but doesn't cover that. But those are kind of the upshots. That again, the vancomycin gives you MRSA coverage, and the zosyn will give you lots of gram-positive, lots of gram-negative, including Pseudomonas. The cefepime will give you more or less the same, and then the carbapenem would give you coverage for the ESBL organisms. How will I know which of those to do? You'll probably have some help, and you would be able to determine from old culture data whether they've ever grown out ESBL organisms, whether they've ever grown out Pseudomonas, whether they've ever grown out MRSA, and use that information to help make that decision. There are risk calculators for how likely is my patient to have a resistant organism, and they include things like they've been hospitalized within 30 days, they go to dialysis every day, they're in a care center, things of that nature. So you would use that information with the culture data to decide. But by and large, it's going to be vancomycin, and if there are any respiratory symptoms, you're adding azithromycin to cover for what they say are atypicals, but you're really covering for Legionella, which we don't really get on the West Coast, but nevertheless. So that's antibiotics, that's source control, and then again, imaging for non-traditional sources. So this is a recommendation. This is the stronger of the two levels of the guidelines. So they make recommendations and they make suggestions. Recommendations are things you have to do. Suggestions are things you at least have to think about. Source control, as I said, an active, urgent search for a correctable cause. CT scans and IR drainage for tubes, lumbar punctures in patients with altered mental status. We talked about each of those things a little bit. And then, for people with infected pancreatitis, currently the recommendations are not to operate on that, but you may find some places where they want to stick a tube in it. But the idea is you're trying to drain and address any sort of collection of infection that you can find. I mentioned these autopsy studies. I won't repeat it here, but the bottom line is if you're dead from septic shock, you had an infection that we were not adequately treating. So I'm going to skip past that. Fluids, we give these people fluids. How much fluid do we give? It says right here, 30 mils per kg within 3 hours. So what does 30 mils per kg look like? Well, that's, in our typical patient, that's going to be 3 liters in 3 hours. I think that's fine as a start. The idea being, however, that you would want to make decisions about fluid based on whether they're actually responding to fluid or not. How would you determine that? Well, they don't cover this in the guidelines, but things that you've heard of would include checking lactate for reductions in response to fluid, assessing hemodynamic changes to fluid boluses, measuring the central venous saturation off of the central line over time as fluid is being given. Things of that nature are all statistically validated to improve outcomes. So the idea is you check something, you give a bunch of fluid, and then you check it again and see if they got better. Historically, people have used the CVP to make decisions about fluid therapy. We don't tend to do that anymore for reasons that we can get into at the end. Patients will have central lines and might have CVPs measured, but generally speaking, we don't want to make fluid decisions based on that. As a quick pause, I see that there's an orange light lighting up, and I'm wondering if that means there are questions coming through the chat. So why don't I take a pause here and review these? Yes, you can get a copy of the slides. I'm glad that people like the cows. Thanks, Karen. Yeah, so Jordan mentions Legionella. I've had one patient in 10 years with Legionella, and he was traveling from the East Coast, but nevertheless. Karen, in patients who are COVID positive, do we still start? Yes, we still start broad spectrum antibiotics, in part because if we're wrong and they had something that was treatable, their mortality is very, very high. So generally speaking, the consequences of the antibiotics for an individual patient are low, and the costs of being wrong are very, very high. Yes, thank you, Marilyn, for reiterating the antibiotics. I appreciate that. There is an ID pharmacist. There is a pharmacist who rounds in the ICU, and they will help with that. And in fact, the surge staffing model incorporates stealing the additional pharmacist from the cardiac surgery team to fill in for that role. So over the years, we've had more and more support from pharmacy, and it's indispensable. And yes, you will have that help. It looks like those are the questions for now. Thank you. What fluid to give? Boy, you could spend an hour talking about what fluid to give, and the only answer is give whatever the hell you want. It doesn't matter. There will be people that will say you got to give them saline. There will be people that say you got to give them plasmolite. Oh, it has to be lactated. Oh, you better not use albumin. It doesn't matter what you give. Sodium chloride might be a little worse, but man, it is so close that you can barely make the call. So much ink has been spilled on trying to answer this question that you want to pull your hair out. Give. It matters a lot less what you give, and it matters a lot more how you give it, which is to say, generally speaking, in large amounts, very quickly, with frequent assessment of the results. I will say that we don't even have starch anymore, so we don't have to go into that, but starch is probably fine too. This is a recommendation. You got to give people fluid. If you don't give them fluid, they're going to die. Here is just one of 1,000 studies on this question, and it doesn't matter. And I will stop talking about that. So I kind of touched a little bit on like sort of how much do you give and when and in response to what. And I will just show, so I mentioned early goal-directed therapy earlier in the talk, and although we say we don't use this anymore, we totally 100% use it. And you can think of these patients in this kind of stepwise flowchart manner. And I actually think even though there are many aspects of this that we don't actually do anymore, I think it is helpful to walk through it and say like, okay, if this, then that, if this, then that, and kind of what are my next moves? It's true that, so okay, this guy comes in with sepsis and he's maybe intubated and has a bunch of central lines and all this. It's true that we don't look at the CVP anymore. Instead, we would just give crystalloid or colloid and assess the response to that. If the blood pressure goes up, we think we've probably done a good thing. If the lactate goes down, we think we've done a good thing. If the central venous saturation gets closer to 70 from either direction, we think that's probably good. So that might make us give more fluid. If you're giving a bunch of fluid and the blood pressure is fine, but you still have lactates, you still have central venous saturation perturbations, and you still have signs of organ perfusion, you would then start thinking about things like, well, do I need more oxygen delivery? What is my contractility? If it's low, I might consider dobutamine. If it's normal, and my hemoglobin is low, I might consider red blood cells. I will tell you that we very rarely give dobutamine and blood for septic shock, but if you look in trials, anywhere from 5 to 20% of patients in some of these studies are getting one or the other of these therapies. So it is true that people get these things, but for reasons that we could go on and on about, we don't tend to do a lot of that here or at Parnassus. But as you kind of walk through, what is this patient's problem? Well, their hemodynamics suck. Okay, now the hemodynamics are better, but their organ perfusion is still bad. How do I make organ perfusion? I either have to give oxygen carrying capacity in the form of blood, or I have to make more oxygen go to their tissues in the form of increasing cardiac output with inotropes. And so those would be the kinds of moves that you might make. Interestingly, if you want to really geek out on this, you can start talking about giving these patients nitroglycerin. It sounds crazy. There's a whole literature base for it, and we can talk about that after the slides. So I don't want you to hang up on this and say, well, I got to check the CVP, I got to do this, but to just have in your kind of in the back of your mind as a frame of reference that there's sort of a stepwise process. I'm going to check something, I'm going to do something, and then I'm going to recheck and see what happened. And that is the way to make people better. I'm not going to talk about the VAST trial in this session, and I'm not going to. I will say that the early goal-directed therapy style of care has been replicated in subsequent studies, but without a finding that it actually made people better. Mostly, I think these studies were underpowered. Because the patients that they recruited were not nearly as sick as the ones that they expected, and so it became much harder to find a difference. The reality is we still need to be doing a stepwise approach to care where you check something, you do something, and you check it again, which is essentially what these modes of therapy have brought to the bedside. Pressors. We have a patient, they're hypotensive, we're given fluid, we're given pressors. Those all sound like good things. What pressure should we give and how much? We want to target a MAP of 65 rather, in most patients. And while there's very little data to guide that choice, that is the number that we've kind of settled on, and that's the number that we're going to use. The drug of choice for these people is going to be norepinephrine, followed by epinephrine or vasopressin, and phenylephrine is not preferred in patients with septic shock. This is an important distinction because if you're diagnosing this patient with hypotension from sedative effect or positive pressure effect, you might use phenylephrine. If you're diagnosing hypotension in this patient due to septic shock, you're going to want to use norepinephrine. And the reasons for that are probably related to the inotropy that norepinephrine provides, which phenylephrine probably does not. This is a recommendation. You got to support their blood pressure. If they don't have blood pressure, they're going to die. I did say that we don't have a lot of data identifying 65 as the right number, but there is at least one randomized trial comparing two different MAP goals. And I would only just very briefly mention this study because it may impact the MAP goals that you might have for specific patients. So they randomized to 65 versus 85. They used norepinephrine, they counted up mortality, and they counted up how often you needed renal replacement therapy. And they subdivided that by whether or not you had high blood pressure before getting septic shock. And as you can see, we weren't very good at separating people along MAP goals. So it really ended up being a trial of the MAP of 75 versus 85, which on the whole found no difference, but patients who were hypertensive at baseline were more likely to develop AKI and require dialysis if they were in the low MAP group. So all we really know is the MAP goal should be 65 most of the time. If there's someone on a bunch of hypertensive meds at home, you might consider keeping them at a higher MAP. That's about as much as we can say. I don't want to get into the nitroglycerin here, but maybe it would save lives when it doesn't kill people, and then we're going to skip past. This is kind of the lactate clearance stuff that I had alluded to earlier. Steroids and septic shock. To give these people steroids, I did mention that some of these patients are going to have adrenal insufficiency, and certainly patients with septic shock can have adrenal insufficiency. The pendulum has swung on this over the years, and I would say that if they have risk factors for adrenal insufficiency, you should give stress dose steroids. We have a dosing protocol. It's a lot of drug, and the pharmacist can help you with the dosing, but it's a big dose of hydrocortisone. How would you make this decision? I think you would want to identify patients that have risk factors for adrenal insufficiency, and those would be things like, hey, I'm on a bunch of prednisone at home and I'm not getting it now. That's a pretty obvious one. Patients who have thromboembolic disease, so the adrenals, because of the large amount of cardiac output that they receive, are at a slightly higher risk compared to other organs for having clot-associated organ failure. Patients who received etomidate, even if just a single bolus dose for induction for intubation, those people are all at risk for adrenal insufficiency. Generally speaking, the trials that showed a benefit from steroids randomized patients earlier. So it's not a great idea to get to like day 6 and say, well, he's on 12 pressors and he's still not getting better. Why don't we give him steroids? The time to think of this is like day 1, day 1.5. And that's a suggestion. So the Surviving Sepsis campaign doesn't think everyone should get steroids, but you should at least think about it. You can snapshot this, or again, you'll have the slides, you can look up these papers, but these are a couple of the seminal papers in this area, and there have been many, many more. Can't swing a dead cat without hitting a trial on steroids. Glucose control, we're targeting under 180, just leave it at that. Insulin is a good thing, probably. I would say that we're trying to prefer not doing insulin infusions in the COVID patients, in part because it requires the nurse to go in the room a lot more. So again, you probably won't be making that decision in isolation, but just in the back of your mind, sort of keep that in mind, trying to keep it simple and trying to keep the nurse out of the room. That's a recommendation. There's a lot of controversy on tight glycemic control, but everybody thinks we should keep it, under 200 at least. Bicarb, wow, gosh, the patient's hypotensive, their organs are failing, they're in shock, and they're acidotic. Should I give bicarb? All that the guidelines say is not to give it if the pH is better than 7.15. That doesn't mean you should give it if the pH is less than 1.5, but it's not totally clear that it helps. So they recommend not giving this for these patients. DVT prophylaxis, and this is the recommendation from 2 or 3 years ago. The pendulum swings on this too. Whether should it be unfractionated, should it be low molecular weight? They should have something, barring some severe risk factor for bleeding, and that's a decision that can be made cooperatively. But most patients are going to be candidates for DVT prophylaxis. Gastric acid prophylaxis is important as well for these patients who are on the ventilator. There are what's the word I'm looking for? Calculators, basically, that say, does my patient require gastric acid prophylaxis? You can Google these, but basically, if they're on the vent, if they're on pressors, if they're coagulopathic, if they're getting steroids, all those people are at risk and so should be covered. And we generally prefer histamine blockers because there's maybe a hint that those people have less VAP, or ventilator-associated pneumonia, than people who get PPIs. Controversial, but if you have to choose, start with an H2 blocker. And that's a recommendation. You should be prophylaxing these people. Food, you got to eat, man. I'm eating right now. Early enteral nutrition is probably a good thing. It's been difficult to demonstrate that in large studies, but we do try to get feeding tubes in these people and feed them early. We are trying to roll out a protocol here that mimics that at UC, where people get their full caloric daily requirement, whether tube feeds are held for procedures or other things or not. So a more aggressive approach to treating malnutrition. So you may encounter that concept where we're running at maintenance doses of food, and then for short periods of time much higher doses and tolerating higher residuals, with the goal of making sure these people have adequate nutrition. It's California, and I'm sure that you've heard that gluten can kill you, and that you should have selenium and whatever. That concept is true in the world of enteral tube feeds as well. And there's been a lot of attention on, well, geez, what if we put a lot of arginine in there? Or what if we put in this, immune modulating chemical into tube feeds? And mostly those studies have not been helpful. We just give them, protein and glucose and fiber, and they do just fine. That's a suggestion, but really, I think it's more of a recommendation. You got to feed these people. At times, we have had different protocols around, like, well, if they're on this much pressure, don't feed them because their gut would be hypoperfused. I think most of us still feel like trickle feeds are probably helpful for these patients, just to keep the gastric mucosa doing something. I imagine, I can see the chat window lighting up. I imagine Marilyn is probably saying that there's no data for that. That might be true, but it is a common practice that you will probably encounter. I'm going to stop at controversies because I want to give people an opportunity to talk and ask questions. And I see the chat window is alive, so I'm going to address that after coughing. It's just pollen. Don't worry, I don't have the virus. All right. Does everyone have their questions? So inotrope, yes, dobutamine is the drug of choice. Yes, daily QTCs in patients on hydroxychloroquine. We do have protocols for Plaquenil. To my knowledge, we haven't had any patients on it, of course. Oh, good. Marilyn mentioned that. If you want to pipe up and unmute yourself regarding the volume boluses in the COVID patients.
Sure. It's just, I'm sure if Jordan gives a lecture on ARDS, there's a lot of concern about keeping ARDS patients in particular on the net even to even a little bit negative side, or at least as fluid neutral as you can, because in patients who are very hypoxic and are in a vasodilatory state, any additional fluid that you give, some of it's going to distribute into their lungs and then make them more hypoxic. So that's the one kind of change from standard sepsis guidelines in COVID, is to at least, give them fluid if they need it, give adequate fluid, but start with small fluid boluses, like 500 cc's at a time, and reassess for volume responsiveness frequently, rather than giving that upfront 30 cc's per kilo bolus.
Yeah, I agree with that 1,000,000%. I think that 30 cc's is sort of like you should be giving that in small doses with frequent reassessment for, is there actually something that's being made better by that fluid? That is super critical, and I agree 100% with that. Nancy asked a really good question. So there is not a clear signal about whether steroids are good or bad for COVID. I will say, for years, we have said that steroids don't make a difference in ARDS, and then the Lancet just publishes a pretty well done randomized trial showing that steroids made people with ARDS better. So there will be a lot of cooks in the kitchen on that decision. So thing one, there are a lot of different evidence bases that you might refer to when making that decision. Am I giving steroids because they have septic shock that's refractory to pressors? Okay, we know that's probably a good thing. Am I giving steroids because they have ARDS? Wow, gee, we're not sure, but there's this one study. Are we giving steroids specifically for COVID? And those are three very different questions. I think that it's probably not that likely to harm them. So if you had a proper indication in someone with septic shock, we'd totally do it. But you'd want to think through those things, like, do they actually have risk factors? Do they have pressor refractory shock? And furthermore, do they get better when I give it? Just because you start it doesn't mean you're obligated to, a 5-day course or whatever. If you give a bunch of steroids and they're not better, you might stop it so that whatever risks were present in these other conditions, that you're not making those things worse. Yeah, Jordan makes a great point. I mean, I'm on some of these threads for the ASA's Committee on Critical Care Medicine, and it's all anecdotal. There are people that swear that, all their patients go on CRT, and there's places that don't have any CRT. There's people that are giving everybody steroids. There's people that aren't using any steroids. So I don't think there's a clear signal on that. Question: some ICU patients get zinc, those with wounds, those with cirrhosis. Oh, maybe I cut out there. Those with wounds, those with cirrhosis, and those with malnutrition on TPN. I know that the tube feeds are supplemented with multivitamin. I assume that has some zinc, but to my knowledge, we don't specifically supplement with zinc other than for those conditions that I mentioned. Thanks, Jordan, for addressing that. Yes, I was not aware of that. If people want to keep asking questions through chat, that's great. If they want to unmute themselves and ask, that's great too. I'm happy to stay on. I have a call at 2:30, but happy to stay on and talk more about sepsis or answer more questions. I'm pleased to have the help of Jordan and Marilyn to help field some of these as well. If people had more questions about the hydroxychloroquine, because that's getting a lot of attention in the press, there are documents that the pharmacy sent out from the VA central office that I thought were quite good. They covered the literature base and the side effects and things of that nature. I will say it seems as though many on the White House Coronavirus Task Force have stock interests in the pharmaceutical companies that make hydroxychloroquine, so that might be why you're hearing so much about it, but I don't think that there's any clear signal that it's effective. Any other, we are, I know at let me think this through. I know at Parnassus there's a trial on one of the antiviral medications. Here, we have the availability of those drugs, including the hydroxychloroquine, but not through trials.
Hey, Chris, I had a question for
Yeah.
you. You know, I've been hearing a lot about using like point of care ultrasound and using that to assess for fluid resuscitation. Is there any evidence for that being used in sepsis per se?
Excellent question. I am kind of alone in the woods on this point, but the reality is there's almost no ultrasound finding that has been adequately assessed for determining fluid responsiveness. So people will look at the IVC and these collapsibility indices, and they'll look at the left ventricle. The truth is, none of those things have ever been evaluated from the perspective of, does this finding actually indicate that their stroke volume will go up in response to fluid? So the answer is really that everybody uses point of care ultrasound because pictures are neat and it gives them something to do. But specifically with regard to the question, is this patient's stroke volume going to get better with fluid? There really isn't anything on the ultrasound that's been proven to answer that question. Really, the best metrics are related to A-line tracings and things like pulse pressure variation, systolic pressure variation, which are calculated by the monitors in the ICU. The challenge with those is that there are a number of conditions that would make those numbers less valid. So for example, if patients are not in sinus rhythm, those estimates will be artificially enhanced. So there'll be false positives. For patients that are on low tidal volume, so below about 8 mils per kg, which is going to be all of our ventilated patients, those estimates will be attenuated. You'll have false negatives. So it's, you know, so if you eliminated all the people who were in AFib or on low tidal volumes, you wouldn't have very many patients left to use these metrics on. So we kind of look at anything you can look at to help make the decision, and then you give fluid anyway, and you see if you were right. That's unsatisfying in 2020, but that's pretty much as good as it gets. I would say that in COVID patients, I would be reluctant to send people into the room to do point of care ultrasound, other than for very concrete things like, is the heart moving and is there a pneumothorax? In part because the devices are difficult to clean, and I don't want to send a human into the room for something that doesn't actually answer a question. Karin asks a good question. We don't measure mixed venous because the mixed venous requires a pulmonary artery catheter. We occasionally do measure a central venous, which is kind of a proxy for the mixed venous. The importance of that number has been de-emphasized as the years go by, but I find that if it is low, it helps me think that I can treat something. So I would say they're not done routinely, but I like them and I do check them. And pulse pressure variation is regularly measured. It shows up on, just as it does in our GE monitors in the room, it'll show up on the bedside monitor in the ICU. So Marilyn mentions that we have 3 doses of tocilizumab. So this is kind of interesting. You've probably heard about this interleukin-6 cytokine storm business, and that if only you could treat the cytokines, patients would get better. I don't know. I've seen a lot of trials of interferons and interglobulins and different ways to sort of mop up all the inflammatory mediators in sepsis, and none of them have been positive. So I don't think you would ever be in a position as a non-intensivist to say, I think I'm going to give this guy some tocilizumab, but I guess it's there, and it would be, if someone gives it, I'd be sure interested in seeing what happens. Temperature threshold, to my knowledge, there is no different temperature threshold for these patients. I think that we try to keep them close to normal if we can to avoid insensible losses and patient discomfort, tachycardia. But I know of no specific threshold. We go through a lot of Tylenol, even without COVID. It raised an interesting point. My mother has been taking Tylenol this last week for who the hell knows, some kind of injury. And she's saying that she can't find any and that it's being hoarded. And I suspect that with all these febrile COVID patients, plus the hoarding, we're going to run out and probably need to establish a threshold under which we will not treat people with antipyretics, but that's for another time. Yes, Marilyn's point is one that I have heard as well, to avoid NSAIDs, which we rarely give anyway, but that we are treating fevers. So that's an interesting question. I mean, physiologically, it kind of makes sense, Karin, right? I mean, if you really think about like what's happening in the patient's body, right? Like, so they're underperfused, and maybe, in their kidney, the blood vessels, these miniature blood vessels aren't actually getting a lot of flow. And so what do we do to make that better? We give a bunch of vasoconstrictor to raise the blood vessel, to raise the blood pressure. But aren't we really just vasoconstricting the very blood vessels that we're trying to perfuse anyway? I mean, that's an open question. The truth is, if you randomize patients to norepi versus not in an operating room, the norepi patients have less AKI afterwards. So there's something about vasoconstricting that does actually make organ perfusion better. Acidosis dilates the blood vessels of organs that aren't getting enough blood flow. It should work. Similarly, giving nitroglycerin to venodilate the veins post-capillary should theoretically suck more arterial blood into those organs. These are things that make sense physiologically. There's not a lot of data behind them. The data that exists, at least for nitroglycerin, are not supportive. I know of no data in the modern era on this acidosis question. So we don't keep them acidotic for sepsis, but for ARDS, we do permit hypercapnia. The idea there being that you can ventilate them bigger, harder, faster to make the pH normal, but that can lead to overdistension of the alveoli, volute trauma, pressure trauma, atelect trauma, and basically ventilator-induced lung injury of different kinds. And so we aren't promoting respiratory acidosis in those patients, but we are allowing respiratory acidosis in those patients. Slightly different from your question, but that you will see patients with respiratory acidosis more or less deliberately so as to avoid ventilator-induced lung injury. These are great questions, by the way. I find this so interesting. In the meantime, I can put up pictures of my dog. Oh, Art, I like your hat. Oh, you're muted. I couldn't hear that. Sorry, but I'm sure it was funny.
Thank you. My head was cold.
Is that the home office? Is that what I'm seeing?
That's the home office. Definitely.
I don't put up my live video either, but it's kind of fun when people do. You get to kind of see what it's like.
I live in a house,
You're a lucky man. Would be delighted to keep taking questions or keep talking about things. I know that like sometimes we can kind of geek out on the physiology, and what people really want are like, well, what do I actually do? And I hope I've covered, what you're actually going to do. How much fluid, which antibiotics.
Chris, can I ask a question?
Yes, please do.
So we were talking about making an order set that has a lot of this stuff in it so that people can click some buttons and do it properly. How far along is that order set, and do I need to encourage people to push it forward, or is it being, I see emails going around for it. Is it in place yet, or do I need to push it, or what's the status of the order set?
I can speak to that a little bit if you want, or unless.
No, please do.
Yes. So after much discussion with the pharmacy and Rachel Rance, what they have the bandwidth to do right now is a general COVID-specific order set that would apply to all patients, not just ICU patients. And it will have a link to our standard ICU order set menu, which, as Chris has just outlined, there isn't really anything specific about the management of COVID patients, either from a septic shock or an ARDS perspective. What we have also done is come up with an ICU protocol for the management of these patients, and there will be a link to that protocol on the CPRS order set for COVID, and I will circulate it to all of you as well. And that's kind of where we've left it with pharmacy. So, and I think that's reasonable because their management really isn't different than the management of any other sick ICU patient with sepsis or ARDS.
I think that's great. Some of the things are slightly different, like the hydroxychloroquine, are we doing that or not? And I think those decisions ought to be made at a higher level than the individual.
Absolutely. So you cannot order any of those medications without the approval of the ID service. And that's very clear from that order set as well. And ID would be involved with all of these patients.
Perfect. Thank you.
There are some differences that are emerging in terms of, and so Marilyn sort of commented that it's sort of regular ARDS care. And I think that's largely true. I'm hearing from people that they're seeing kind of two different phenotypes of these patients. Some where they kind of have the crummy compliance, stiff lungs, and they look like ARDS patients, and some where they don't have that. If anything, they have enhanced compliance and yet just awful oxygenation. So you're getting up to these ridiculous amounts of PEEP, 25, 28 of PEEP, just to kind of optimize them, but they're not, there's some kind of H phenotype and L phenotype, and I need to read a little bit more about it because this is just coming across the wires. But that those distinctions probably won't be that relevant for the individual clinician. That's something we'll have to work out kind of with RT on whether we need different kind of ARDSNet pathways for some of those patients, and that may evolve as we start seeing patients. But that was an interesting difference that I had not heard of until very recently.
Because Chris, there's a bunch of discussion, sort of the Italians, that there's two types, and that some of these people have microvascular dysfunction in the lung, and that the ARDS isn't as responsive to high PEEPs.
Yeah, I was going to the ARDS talk, which I have up on YouTube right now, but I can't get into my VA email to actually send the link out to everyone yet. But it is touched on, and that's one thing that's been reported in numerous centers, that there's sort of the two phenotypes. It's not clear exactly what's going on in the non-PEEP responsive group. It may be an issue of distorted microvasculature in the lung. Some people there's all these theories about what's actually happening. The bottom line is that proning patients seems to actually help in both cases, because we know it can benefit traditional ARDS patients, and there's a lot of experience now with proning even non-intubated patients with COVID in a lot of centers. They just have people literally like lie on their stomachs, and that seems to improve their oxygenation. So
yeah, we call that tummy time over at Parnassus. We're doing a lot of it.
Exactly. It seems like it's not 100% clear what's going on, and I'm sure there's going to be a lot of physiology, worked on in the next couple of years. But I think that's out there. Anyway,